Hey there, everyone. Welcome back to GME Compass. I'm Julie Gualano, and today's topic is one that can have a fairly significant impact on the effectiveness of your Clinical Competency Committee meetings. It's often received very little formal training. How to present your trainees during your CCC. Many programs spend tremendous effort collecting assessment data, but when it comes time to discuss your residents and your fellows during the committee meeting, the presentation process is often very inconsistent. It's highly variable and dependent upon who happens to be presenting the information. The reality is that how a trainee is presented can dramatically influence committee discussion, milestone recommendations, recognition of advancement, and even decisions regarding remediation. Today, we're going to discuss best practices for presenting trainees in a way that is objective, evidence-based, developmental focused, and aligned with the true purpose of the Clinical Competency Committee. So let's jump in. Before we begin, a few disclosures. I have no financial disclosures related to this presentation. The information shared today comes from the broad continuum of experiences that have shaped my career in graduate medical education of almost 2 decades. The content reflects personal knowledge, observations, and experiences. It's not intended to represent any current or past GME roles or organizations. As always, I encourage viewers to review the most current ACGME common program requirements and specialty-specific requirements applicable to their programs. By the end of today's session, you'll be able to describe the purpose and key elements of effective CCC presentations. Use multiple sources of assessment data to present trainees objectively. Engage committee members in meaningful discussion that supports balanced decisions. Document outcomes and recommendations effectively, and perhaps, most importantly, identify opportunities to improve your own CCC processes. While today's topic sounds straightforward, effective trainee presentations often separate high-performing CCCs from committees that simply review data. Why presentation style matters. Many people assume that committee decisions are driven solely by the data. In reality, presentation style matters tremendously. The way that information is organized, the way that it's emphasized, the way that it's communicated influence how committee members perceive a trainee. It's communication 101. Presentation style can affect the discussion from the committee, milestone recommendations, early intervention decisions, recognition of advancement, documentation quality. Ultimately, it can even affect learner development outcomes. If a trainee is presented primarily through the lens of deficiencies, the committee may focus disproportionately on the concerns. Conversely, if significant concerns are minimized, if they're overlooked, opportunities for intervention might be missed. The goal is not to persuade the committee. The goal is to provide a balanced, accurate developmental picture that allows the committee to make informed decisions. I always looked at the presentation of a trainee at the Clinical Competency Committee almost as a sign-out presentation because it's something that should not be positively or negatively biased. It should be presentation of the facts. When you're presenting a trainee, there's 5 key questions that every presentation should answer. Where's the trainee now? How have they progressed over time? What evidence supports the assessment? What concerns require attention? And what strengths deserve recognition? Notice what's not on the list. Nowhere does it say read every evaluation. Nowhere does it say summarize every comment. Your role as presenter is to synthesize the information. Think of yourself as translating assessment data into a developmental trainee story. The committee doesn't need every single detail. They need meaningful information that helps them to understand the learner's trajectory. An effective way to begin is by providing context. Start with the trainee's PGY level, key rotation experiences, major educational activities, overall trajectory, previous CCC recommendation, follow up on prior concerns. This immediately grounds the committee in where the learner is within their training. For example, a concern about an independent decision-making may be entirely expected in a first-year trainee, but much more concerning in a senior resident approaching graduation. Context matters. Without context, assessment data can be extremely misleading. Focus on your trends, not individual evaluation. This is a very important slide. Your CCC exists to identify patterns. It doesn't exist to focus on isolated incidents, not a bad day or an outstanding rotation. Very often, presenters read evaluation after evaluation and force committee members to identify trends themselves. Instead, your presentation should be identifying recurring themes. You want to look for progression and consistency and patterns across time and across different evaluators. So, for example, instead of saying Dr. Smith's evaluation mentioned concerns about communication, you want to say something along the lines of communication concerns were identified by 3 faculty members across 2 different rotations during the last 6 months. That tells an extremely different story. Also, strong presentations rely on multiple assessment sources. Faculty evaluations are important, but they're only one piece of the puzzle. Additional data can include things like their procedure logs and their procedure logging, milestones, simulation assessments, patient feedback, peer evaluations, nursing evaluations, scholarly activity, border in training exam performance, professionalism reports. And there's so many other objective measures. When multiple data sources point in the same direction, confidence in the assessment increases. The ACGME expects milestone recommendations to be evidence-based. That means using multiple sources whenever possible. A healthy habit that a clinical competency committee can develop is intentionally identifying strengths. Too often, discussion begins with what is wrong with this trainee. Instead, starting with what is this trainee doing well? Maybe they're demonstrating strong clinical reasoning. Maybe they're highly professional. Maybe they're becoming a leader within their residency program. Maybe they've shown remarkable improvement. Strength recognition matters. It creates balanced discussions. It improves fairness, and it reinforces that the purpose of assessment is development, not fault finding. Many committees, and truly the culture of medical education, is very good at identifying deficiencies. Fewer are equally good at recognizing advancement. Yet advancement is equally important. Ask, where has the growth occurred? Which milestones demonstrate the progression? What skills have matured? How does current performance compare to previous reviews? You want to remember that a trainee who improves from struggling to meeting expectations has really achieved something significant. Growth deserves discussion, documentation, and recognition. When you're thinking about how to organize your presentation of your trainee, a framework that I recommend is strengths, growth areas, trends, concerns, and then recommendations. This structure keeps presentations focused, streamlined, and consistent. Consistency benefits both the presenters as well as the committee members. When every trainee is presented using the same framework, comparisons can become more reliable and discussions can become more efficient and effective. The committee spends less time trying to understand the presentation format and more time actually analyzing the learner performance. High-performing CCCs identify concerns before they become crises. Some common red flags, and we've talked about this throughout the series, is declining evaluations, exam failures, incomplete documentation, frequent complaints. One isolated concern might not be significant. However, repeated concerns across multiple settings often indicate an emerging pattern. The earlier that these patterns are recognized, the more opportunities that exist for successful intervention. That being said, not every concern requires remediation. This is an area where committees sometimes tend to struggle. Ask yourself, is this developmental? Is it isolated? Is it improving? Is it patient safety affected? Would additional support be sufficient? Many concerns are part of normal learner development. Residents and fellows are still learning. The purpose of the CCC is not to hone in on and obsess on every single weakness. It's to determine what level of support is needed in order to facilitate growth and an upward trajectory. That being said, there are circumstances when formal remediation is appropriate. Typical concerns are when it's persistent, recurrent, significant, impacting patient care, and it's affecting professionalism. It's also necessary when it's resistant to coaching and routine educational interventions. The decision to recommend remediation should never be based on emotion or anecdote. It should be based on documented evidence demonstrating that routine support strategies have been insufficient. When discussing a trainee that's already on remediation, you want to focus on progress. You want to include things like the reason that the remediation was initiated, deficiencies that were identified, goals established, progress achieved, remaining concerns, and evidence supporting improvement. One mistake that committees sometimes make is continually revisiting the original concern while failing to assess whether improvement has occurred. The purpose of remediation is growth. Your presentation should demonstrate whether growth is occurring. There are several traps presenters need to avoid. Avoiding your personal opinions of the trainee, labels, hearsay, rumor, unverified concerns, emotional language, comparing trainees to their peers. Statements like, she's difficult, he's lazy, she's not a team player. They're all subjective and they're not helpful. Instead, focus on behaviors, observations, and documented evidence. The committee should evaluate performance, not personality. Also, language matters. Consider the difference between she's struggling clinically and faculty evaluations from 3 rotations identified recurring concerns regarding diagnostic reasoning. The first statement's vague and it's very subjective. The second statement is specific and it's evidence-based. Objective language increases fairness, transparency, and credibility. It also improves documentation should decisions later need to be reviewed or justified. You want to be sure that you're encouraging committee discussion because the presentation is not your discussion. That's just what you're laying out on the table. It's the starting point for the discussion. You want to ask your committee members, what patterns do you see? Are there additional data sources available? Has anyone observed improvement? Are there missing perspectives? The collective wisdom of the committee is often greater than any individual reviewer's perspective. Encouraging thoughtful discussion strengthens your decision-making of your committee. Once discussion concludes, documentation then becomes extremely critical. Document your milestone recommendations, strengths identified, concerns discussed, follow-up plans, and your support strategies. Remediation recommendations, if it's applicable. Good documentation creates continuity between meetings and it helps to ensure accountability for both your learner as well as your programs. The most effective presentations are consistent, concise, objective, evidence-based, development-focused, and action-oriented. Notice none of these characteristics require longer meetings. They require better organization and clearer thinking. A concise, focused presentation often produces far better discussion than a lengthy review of every single data point that's available. And we're back to our reflection questions. So as you think about your own CCC process, think about things like, do your presentations focus on trends? Are the strengths discussed consistently? Are concerns identified early? Is advancement recognized? Are recommendations actionable? What could be improved? Every CCC has opportunities for growth. Remember, this is medical education. Perfection doesn't exist. It's never going to happen. There's always opportunities for growth and improvement. And as we wrap up, remember these key principles. Present developmental stories, not evaluation summaries. Focus on trends, not isolated events. Use multiple assessment sources and recognize advancement as intentionally as you recognize your deficiencies. Identify red flags early on. Use objective, evidence-based language and support learner growth through meaningful committee discussion. These practices help to transform your CCC meetings from compliance exercises into very powerful developmental conversations. The best CCC presentations do far more than report simply data. They give patterns, recognize growth, uncover concerns, guide interventions, and support learner success. Ultimately, they help to transform assessment information into meaningful developmental decisions. When done well, CCC presentations become one of the most important tools that we have for supporting trainees throughout their educational journey. So thank you for joining us today. If you found this session helpful, please consider liking this video, subscribing to the channel, and sharing it with your colleagues involved in graduate medical education. At GME Compass, we help to guide GME professionals through complexity with confidence while building stronger programs, stronger systems, and stronger learner outcomes. We appreciate your support and look forward to seeing you in our next episode. Until then, continue building systems that support growth, promote excellence, and help your learners to succeed. Thank you for being a part of the GME Compass community. Thank you, everyone. See you in the next video.